Good morning, everybody. Before I start, can you please make sure that your cameras and microphones are switched off throughout the session so they're not a distraction to the speaker? I'd be very grateful for that. I'll just turn my camera on. The session is being recorded. So it's absolutely fantastic to see so many people here today, and you can see there's people arriving second by second. There's more people arriving, which is fantastic. So I'm Holly Blake. I'm a trustee of the Institute for Health Promotion and Education, and I'm a Professor of Behavioural Medicine at the School of Health Sciences, the University of Nottingham in the UK. And I'm also a trustee of the Institute for Health Promotion and Education. I'm representing both organisations today, and I'll be acting as your host in the third masterclass in our 2025 series, which is all about advocating for positive health, preventing ill health and reducing inequalities. So let me tell you first about IHPE. So we are a registered charity, and we're an international network for professionals in health promotion and education. Members of IHPE are unified in their ambition to protect and improve public health and to reduce inequalities, and the network promotes collaborative working, supporting members to share ideas, share information and share experiences. And it provides the opportunity to unite as a single voice in support of actions designed to promote individual and population health. The benefits of joining us include 6 issues per year of the peer-reviewed International Journal of Health Promotion and Education, and permission for post-nominal letters to acknowledge membership. I'm going to share a little bit more information about this at the end of the session. But let's move on to our masterclass topic today, which is prevention of obesity in children and adolescents. Our speaker today is Professor Louisa Ells. Louisa is Professor of Obesity at Leeds Beckett University in the UK, and she co-directs the Obesity Institute as well. And Louisa is an advocate of the voices of lived experiences and specialises in compassionate, multidisciplinary, cross-sector applied obesity research that addresses real-world priorities. She is a registered public health nutritionist. She's fellow of the Royal Society for Public Health. With a wealth of research and public health experience, she's acted in advisory roles for several national and international institutes, for example, the National Institute for Health and Care Excellence and Public Health England, which is now the Office of Health Improvement and Disparities. Her research focuses on obesity-related public health, on service evaluation, on inequalities, disordered eating, delivered using systematic reviewing, mixed methods, co-production and a range of person-centred approaches. And her research profile is evident in that 2025, she's been awarded an NIHR Senior Investigator Award, which is really fantastic. So congratulations, Louisa, for that. I'm now going to hand it over to Louisa and turn my camera off, and we look forward to hearing more about your topic area.
Thanks, Holly, for such a lovely introduction, and thank you to all of you for joining me this morning. It really is a great pleasure to speak to you today about the importance of obesity prevention in children and adolescents. So what I'm hoping to achieve over the next 35-40 minutes is to provide you with a bit of an introduction to the complexity of obesity and the need for person-centred care, why preventing obesity is so important, as well as an introduction to the NHS 10-year plan, current evidence base and NICE guidance around prevention. So I apologise, it will be a bit of a whistle-stop tour, but hopefully there'll be plenty of time for some really good discussion and questions at the end. So, oops, there we go. So I thought a good starting point would be to reflect on this article. It was published relatively recently in nhsmanagers.net, where the authors posed this question: is overweight and obesity always just because of eating too much or taking insufficient exercise? I wonder how many of you think the answer to this question is yes. Well, the authors of this report certainly did. However, we know the correct answer to this is almost always no. Because although the fundamental causes of weight gain result from an energy imbalance, we know that the reality of obesity is it's a highly complex chronic disease, which is really nicely illustrated in the aptly named Forsyte spaghetti diagram. It was undertaken back in 2007, but it's still a really good illustration, because they identified over 100 different drivers of obesity, ranging from the impact of individual biology and psychology to the impact of the wider environment and the society that we live in. It highlights the impacts of those choices we can make, but importantly, it highlights the impact of those many choices that are completely out of our individual control. And this is what it feels like. Oh, sorry. Oh, sorry. I think I had a slide missing there. So this is what it feels like to be a patient stuck within this complexity. So this is an image from Ken Clare, one of our amazing patient advocates. And he actually asked AI to draw what it felt like living at the centre of the complexity of obesity. So this diagram came up with this tangle of interwoven complications that need to be carefully unravelled together. As we know, what happens if you just pull on one of these threads, the knot just gets tighter. And I just think this is a really lovely illustration as to why person-centred care is so critically important in supporting patients living with the complexities of obesity. So what is person-centred care? It really is about putting people living with obesity at the heart of their care. And this involves providing personalised and coordinated care. So this is care that considers the social, the cultural, emotional and environmental factors that impact care. It recognises the need for coordinated and multidisciplinary care. It acknowledges the need for changes and the challenges to care that occur across different settings and also across different life course stages. It's about enabling patient-centred care through flexible service specifications and joined up care pathways. Importantly, it's about providing dignity, compassion and respect. Where we eliminate weight stigma and bias, we always use person-first language, we always ask permission before weight is discussed, and we ensure that all conversations are positive, helpful, supportive, collaborative and understanding. It's about enabling care, so supporting patients to use and interpret accessible and appropriate information and resources about their care. It's about acknowledging that patients and professionals might actually have different expectations, but both are equally as important. And it's about optimising the usability, accessibility and trust in digital health where this is appropriate. There are a couple of really good examples of person-centred care frameworks, but I have to say my go-to is the Canadian 5 A's approach, which I think provides a really fantastic international framework for patient-centred care. So, why is preventing obesity so important? Well, firstly, we know that if obesity develops in childhood and adolescence, it can lead to the development of numerous serious conditions, such as early onset cardiometabolic diseases, liver, respiratory, gastrointestinal and musculoskeletal conditions, as well as really serious psychosocial impacts. This can have a huge impact in terms of quality of life, school absenteeism, and it also increases the risk of retaining obesity into adulthood and therefore suffering from the risk of ill health, premature mortality and poor employment outcomes and chances that come with living with obesity in adulthood. Secondly, we know that obesity affects millions of young people globally. So in 2022, the WHO estimated that 1 in 8 people in the world were living with obesity. Worldwide, adult obesity has more than doubled since 1990, and adolescent obesity has quadrupled. Over 390 million children and adolescents aged 5 to 19 years were identified as living with overweight in 2022, and this includes 160 million who were living with obesity. And in 2024, 35 million children under the age of 5 were identified as living with overweight. And this global crisis, unfortunately, is mirrored across England. So to demonstrate this, I'd like to share with you some slides from the Office of Health Improvement and Disparities' latest slide deck. So let's first take a look at the Health Survey for England data, which last measured a representative sample of children and young people in 2022. And it demonstrates two really important things to me. The first is it demonstrates how obesity prevalence increases with age. It also shows us the really important relationship between child and parental weight status, where here in this chart you can clearly see that parents living with obesity are far more likely to have children living with obesity. And this is likely due to a combination of both shared genetics, but also that shared environmental and social influences. However, probably our most robust source of childhood obesity data comes from our National Child Measurement Programme, which annually weighs and measures all 4 to 5 and 10 to 11-year-olds in reception and year 6 across all state-maintained schools in England. I think the measurements usually measure around 1 million children each year. The latest data from the NCMP shows us that nearly 1 in 10 4 to 5-year-olds and over 1 in 5 10 to 11-year-olds are currently living with obesity. And as you can see, things really sadly haven't improved over time since the data was first collected back in 2007. We did see a huge spike during the COVID-19 pandemic, and at least for the reception children, levels have returned back to pre-pandemic levels. But unfortunately, the same can't be said for our older children, where prevalence of excess weight still remains higher than pre-pandemic levels. Obesity prevention is also really important because it's related to some really quite stark inequalities. It does not affect all groups equally. We know that children living in the most deprived areas in the country are significantly more likely to live with obesity compared to those in our most affluent areas. And this is creating a huge inequalities gap, as you can see from these two charts. And sadly, this inequalities gap only increases over time and age. And these gaps are even more stark when you look at those children who are living with the most severe forms of obesity, with children from our most deprived areas 3 times more likely to live with obesity in reception and 4 times more likely to live with severe obesity in year 6. Now, this is really important, as these are the children who are far more likely to be developing those really serious complications and adverse outcomes that we discussed earlier. We also know that obesity prevalence varies by ethnicity, with prevalence highest amongst children from Black ethnic groups in our reception age group and most non-white British ethnicities in year 6. So I thought I'd finish this section with this Sankey diagram, which shows the weight status tracking of individual children between reception and year 6. It shows that the majority of children in reception are a healthy weight and how this weight status changes over time. And to me, the key standout message from this diagram is the absolute importance of early intervention and prevention. So, what is prevention? There are 3 types of prevention that you may well have heard about. The first is primary prevention, where you're aiming to avoid BMI increase in that healthy weight population group. The second form of prevention and secondary prevention is where you aim to avoid the increase from overweight to obesity. And finally, we have tertiary prevention, where you want to avoid an increase from obesity to severe obesity and the development of those really severe and complex complications that might come with that. So what might prevention look like? Well, I thought a really good starting point is the hot off the press NHS 10-year plan, which have several key pledges relating to obesity prevention. So the first section is From Sickness to Prevention, the Power to Make the Healthy Choice. This section launches what they call the Moonshoot to End the Obesity Epidemic, where they have pledged a restriction on children's junk food advertising, a ban on energy drink sales to under 16s, a drive to reformulate the soft drinks industry through the soft drinks industry, and also to bring about mandatory health food sales reporting for those larger food companies. This is in addition to restoring the value of Healthy Start, expanding free school meal eligibility, and updating the school food standards. This section also pledges to harness the recent breakthroughs in weight loss medication, encouraging citizens to play their part through a new health reward scheme, and also, really importantly, expanding mental health support in schools, as well as providing additional support through the Young Futures Hubs. And this is so important because we know there is a very clear bi-directional relationship between poor mental health and the development of obesity. The section on Powering Transformation, Innovation to Drive Healthcare Reform pledges to launch a new large genomic study to help explore personalised prevention of obesity and also to make wearables standard in NHS prevention and treatment. In the section From Hospital to Community, there is a pledge to support the development of multidisciplinary community one-stop shops, which is certainly a service I think will be welcomed by many people living with obesity. I've certainly spoken to many people living with obesity who are incredibly frustrated by the current lack of joined up care and the service postcode lottery that currently exists. So from our kind of national policy perspective, I thought it'd be useful to think about recommendations around prevention within practice. So also relatively hot off the press is the NICE obesity guidance, which was updated, or which the update was published earlier on this year. So this provides information and support to help people to maintain a healthier weight, with guidance on communication, advice, support and tailoring, with specific professional guidance for a range of different settings and local and regional strategic partnerships. And what was most fantastic to see in this latest guidance document are the new principles of care. So apologies, this is a bit of a busy slide, but it gives you an overview of those key principles around respect, support, knowing individual life circumstances, helping when talking about weight, and understanding how patients feel. And this is so lovely to see that those core principles of compassionate, person-centered care and the importance of addressing stigma really runs throughout these principles. And this is so important when working with children and young people, because we know that weight-related bullying and stigma can lead to poor self-esteem, to depressive disorders, impaired school performance, and decreased social involvement. This in turn can lead to increased risk of developing eating disorders and unhealthy weight control behaviours, which we know can then lead to further weight gain. This horrible, vicious cycle, this negative feedback loop really has to stop. So what can the scientific evidence base tell us? Well, this evidence base is absolutely vast. So I thought probably the most useful summary would be to share the latest Cochrane review evidence on the prevention of child and adolescent obesity, which was published last year by Carolyn Somerbell's group. So there were 2 reviews, one looking at primary school aged children aged 5 to 11 and one looking at secondary school aged children 12 to 18. So if we look first at the primary school aged children review, they identified 172 different studies, many of which really predominated from high-income countries and within school settings. However, they did find that strategies for changing activity levels with or without diet did actually help in preventing overweight and obesity within this age group. However, there was little information on adverse events, although where they were described, there appeared to be no or little adverse events or effects. And there was also insufficient information in terms of assessing how well strategies worked for children who might be living with disabilities or for interventions that were conducted within a community setting, which again, really important for prevention. So if we look at the secondary school age group, the review evidence-based was slightly smaller. They identified 74 studies and found a very similar predominance of evidence from high-income countries and also school settings. Similar to the primary school review, they also saw a lack of data on adverse events, community settings, and for children living with disabilities. However, unlike the younger children, this review found that diet and/or activity interventions made no or very little difference on obesity prevention. There could be many different explanations behind this, but it could be related to the increases in autonomy that our older young people have, and also maybe the bombardment of other external influences such as social media, which we know are really prevalent within this age group. But to me, the take-home message from this, again, relates back to the importance of intervening early. It looks like interventions within our primary school children are more effective at preventing obesity, therefore, and we, going back to that Sankey diagram, we really want to prevent that excess weight gain in those healthy weight children and preventing those children living with overweight developing obesity. So the earlier we can intervene, the better. This lack of evidence on children living with disabilities was also identified in a rapid review of qualitative studies that I undertook for Public Health England back in 2020. So this review concluded that weight management programmes, including the assessment and health promotion tools, really do need to be co-developed with children and young people to ensure that they are designed appropriately and tailored to meet need in order to really address these widening and concerning inequalities that we're currently seeing. And this is why co-production and public and patient involvement and engagement is so critically important. So for anyone who might perhaps be less familiar with co-production, it's the sharing of information and decision-making between service users and providers, which, when effectively applied, can improve services and enable service users to become more effective agents of change. Increasingly, it's being used to bring together academics, policymakers, practitioners, and service users to provide high-quality research that has a real and tangible benefit to people's lives. And therefore, good public and patient involvement and engagement is key. So, what is public and patient involvement and engagement, often shortened to PPIE? It's research that is carried out with or by members of the public or patients, rather than to or about them. It really is about creating a truly person-centred approach. It's about putting people at the absolute heart of everything we do. It's about co-developing, co-delivering and co-evaluating services and research with the people that need the most. In turn, this brings a new and different perspective. It improves the quality of your research or service, and it ensures your research or service, importantly, is relevant to your end service users. If you're keen to learn more about good public and patient involvement and engagement, we have some great free resources and training on our website. So I would certainly encourage you to look at that and to download at your leisure. So before I end, I'd really like to share with you our latest piece of co-production, where we worked with the most amazing group of children, families, clinicians and schools to co-develop a short animation to address weight-related bullying in primary school children. And this came about because we've spoken to so many people who have expressed concern as to the number of children that are experiencing weight-related bullying and stigma within school, and we just had a real passion and drive to try and do something to address this. So I'll show you the film shortly. It's only a couple of minutes. It's available free to download and use from our website. We've also put together with our teaching colleagues a teaching resource pack that has several lesson plans that are all aligned to the PHSE curriculum for Key Stage 1 and 2. This will be formally launched in the new academic year in September, but if you would like a copy of the pack beforehand, please do email me and I'd be really happy to share it. Again, like the film, it will be freely available. We're just so keen for anyone to use this to try and make a difference in addressing this important agenda. So I'm hoping the technology will now work and I can show you the film. So I hope everyone was able to hear that, but that was just the most amazing pleasure to be able to work with our young people. They designed the characters, they wrote the script, they did the voiceover. They were just absolutely amazing. And what I just passionately hope is that this will start to make a difference. And we are also starting work in September on a short film for secondary age children as well. So as I say, that's free to use, so please do use, and please do contact me for the teaching pack if it will be a useful resource for you. So in terms of my key take-home messages for today, it really is that child and adolescent obesity is a highly complex disease, and it's also a key policy priority for the UK government. If we don't prevent child and adolescent obesity, we know it can lead to the development of several really serious diseases, which can significantly impact children's quality of life, health, and educational outcomes. We know that too many children are currently living with obesity across the world and in England, and that prevalence of obesity increases with age. Therefore, early intervention is absolutely critical. Obesity doesn't affect all groups equally, as children living in areas of deprivation from certain ethnic groups and with disabilities are more likely to be affected. Addressing these inequities associated with obesity is an absolute priority, and this needs to be undertaken by inclusive co-production and public engagement to ensure that interventions are equitable and also tailored to need. Weight stigma in childhood can lead to poor health, well-being and social outcomes and must be eliminated. People living with obesity should be treated with respect, compassion, and supported through non-stigmatizing, person-centered care. So before I open up for questions, I thought it might be useful just to reflect and to leave you to contemplate some of the research questions that are still outstanding around child and adolescent obesity prevention. So some of them that jumped out in me are really trying to understand what is the most effective way to monitor and evaluate community-wide approaches to obesity, because often our kind of gold standard randomized control trial model is just not appropriate for these types of interventions. So what models work in order to be able to demonstrate success and also to learn from things that don't work? What factors are necessary for an effective and cost-effective community-wide approach to obesity prevention? And also, importantly, how might these vary for different population groups? What impact do families and carers have on the outcomes of obesity and overweight interventions? What are the key barriers and facilitators to participating in interventions for children and young people who are living with overweight and obesity and their families and carers? How can we improve obesity prevention for groups most at risk? So as we reflected on today, really thinking about those children living in our most deprived areas, thinking about children from diverse ethnic heritages, and also thinking about those children who might be living with intellectual or physical disabilities. And then finally, we need to think, are there any adverse effects of identifying children and adolescents as living with overweight and obesity, particularly thinking about the impact of stigma, how we manage that, and also the risk of developing disordered eating patterns or eating disorders. So that, and again, I do apologise, that was very much a whistle-stop tour, but hopefully we've got a good few minutes now for some really good discussion, and I'd be really happy to answer any questions that you might have.
Thank you, Louisa. That was absolutely wonderful presentation. I really enjoyed that, and so much information there on the slide. So just for everybody's reassurance, we'll be sharing this recording on the IHPE website in due course. But thank you very much. Fantastic presentation. I'm going to host a Q&A now from the questions in the chat. So if you do have things you want to ask, we'll get through as many as we can from the chat. But I just want to start with, there's a very big question actually that was posted quite early on. The new NHS plan, how many marks out of 10 would you give it for healthy eating and obesity prevention? There's a separate follow-on question. Do we still need a separate health promotion strategy for this area?
Yes, I would say most definitely yes. I personally wasn't particularly overly impressed with. There's a lot of support for things that were already in progress, and obviously, I mean, I'm going to say this because, you know, I work in this field and I care passionately about this patient group, but I think there's a lot more room for improvement. So I'd probably give it a 5 out of 10. Good, but could do better.
There's offers to help share and disseminate the information from your research and findings and knowledge, and to share your toolkits and resources in the chat as well, and the IHPE will be willing to support that. There's comments around postnatal and pregnancy and breastfeeding as well. I don't know if that's something that your research spans into, or if it's like out of scope.
It's probably slightly out of scope for the research that I do. It is a really key area, and, you know, also the importance of that life course approach, thinking about preconception right the way through pregnancy and then postnatally. Really, really important. I know there's some fantastic work in areas such as Newcastle at Sheffield that really do some fantastic work in this area, but no, it's not my particular area, although very, very important consideration, as I say, as part of that life course approach.
Fantastic. I've got another question here. Is it difficult for practitioners to get a healthy lifestyle message across against the background noise of the extremes of the fitness industry and body positive movement, particularly with older children accessing online content?
Yes, I think it can be difficult. I think the more confidence you gain from doing it more and being trained in compassionate approaches, and I guess it is the importance of language, using language that those young people can relate to, signposting to resources that young people relate to. I was involved in the Action Teens study a few years ago, and really sadly, young people were more confident in going to the internet and YouTube than they were going to their GP, which I think kind of gives a kind of benchmark as to where we sit in young people's priority. So, but I think the importance of language is so important, and the importance of that person-centered and holistic approach. It's actually about understanding everything that's going on in that young person's life, not just focusing in on their weight and numbers on a scales. It's actually about that holistic well-being. And I think if it's approached with the correct language and in a compassionate and sensitive and supportive and helpful way that signposts to resources that resonate with that population, it's definitely possible.
Perfect. I'm going to ask another question from the chat. We've asked for questions via the chat, but I am aware that not everybody will be able to access chat. And there's somebody with a hand up who we'll come to in a moment. But just one question here. Do you have any tips for helping healthcare professionals who are directly involved in weight management to understand that it's not simply about eating less and exercising more?
I think just having that conversation with people, you know, because I know that so many people living with obesity are really fearful because they've had such stigmatizing contact with healthcare professionals. So I think the more we can do to publicize that message, so we can encourage people to engage. But actually, I think asking permission to discuss weight and being upfront about acknowledging the complexity of obesity from the very beginning. And again, sort of going back to that 5 A's framework that I often use in my teaching, you know, it's actually about asking whether there's permission to discuss weight, but then, you know, thinking about comorbidities, thinking about wider lifestyle challenges. So many things that drive obesity are completely out of our individual control, and so I think explaining that and then supporting and empowering patients to do what they can to manage comorbidities effectively and really consider that holistic approach, you know, within the messy context of the real world. I think just being empathetic and being upfront about that message first and foremost is really helpful.
Okay, thank you. I'll take the question from the person with their hand up, Fiona.
Hello. I had put in the chat, I know that you had, by the way, it was an excellent presentation and thanks very much for it, But I know you'd mentioned there was a research gap. It's just that I've done research that is exactly what the gap is. So I thought you might be interested if you wanted to explore it further. So my research that was at doctorate level as a thesis was on children and young people and obesity and the parents' role, and it was about obesity. So I've got all of that if you wanted to explore that.
I'd love to explore it. Yes, thank you very much.
Yeah, I've put my email address in the chat because I think it might be useful for the gap that you're trying to sort out. So because there's already a whole lot being done on it. So yeah, if you wanted to get in touch, my email's in the chat.
Brilliant, that's super great.
Perfect.
And there is some fantastic work starting to emerge. I led the Cochrane Review series looking at treatment interventions for children and young people a few years ago, and the evidence that was coming out of that was again the importance of early intervention, with the treatment interventions being sort of effective in the younger age groups, but also the impact of that dual parent child approach. We've seen in the data that there's that strong relationship between living with obesity as a parent and having a child living with obesity, and thinking about how we can support that family unit. We know that children are far more likely to be successful in their weight management journey if parents who might also be suffering from weight management problems are also supported in their journey, and that can be approached as a kind of as a family approach. So yeah, really, really important. Always love to read more.
Great, and these sessions really do serve as an opportunity to sort of share latest research as well, which is really great. There's loads of questions in the chat, so I'm just going to work through some of those. There's a question here. I would like to hear your views on ethnic adjustments for weight measurements for children and adults, please.
I very nearly put in a slide about this because it's something I'm very interested in. So for those of you who don't know, the current UK 90 growth charts, which is what we use to classify weight status for children and young people, is based on almost entirely on a white Caucasian population. And we know there are significant differences that need to be considered. We know there are different cut points for adults from different ethnic groups. I know there's some fantastic work currently going on in London at Imperial and I think UCL around looking at developing ethnic specific cut points and growth charts. So I think it is a really important consideration, and I'm hoping that there will be more emerging in this field to help us, hopefully very soon. But really, really important consideration.
Brilliant, thank you. And I'm going to move to Elizabeth, who's got her hand up. Do you have a question? Okay, I'm going to move on to another question.
Sorry.
Oh, you've got your mic on.
I forgot to take my microphone off. Great presentation, thank you very much. Just to kind of share again something that a pilot that we've got in place down in Devon is specifically around, so I'm a designated nurse for our children in care and young people in Devon, and we have got a little bit of funding supporting a compassionate approach, a different approach, obviously for children and young people living with adversity and trauma, it very much based on that compassionate approach. So I'd love to share that with you as well. I'll link in with you after with that. So
that would be amazing. I mean, I'm a huge advocate of the compassionate approach. I know Doncaster and several other areas are doing some amazing work in this field. So yes, I would love to know more. And I couldn't quite squeeze it into this presentation, although I was desperate to, because it really isn't even tertiary prevention. But one of the really exciting projects that I'm co-leading with my colleague Kath Homer at SHU is the evaluation of the complications in excess weight clinics for children and young people. And that is producing some really, really interesting learning. So if there's an opportunity to come back and share that with you next year, I would be absolutely delighted to.
Brilliant. I'm going to challenge you on that compassionate approaches, because we've got a question here in the chat. Is training in compassionate approaches even effective? The pressures in the system and in discrete services means that practitioners literally don't have the time to employ these approaches, hence why they default to regurgitating traditional health promotion advice. What's your feeling around that?
I mean, I've got lots of friends who are GPs that, you know, have said so many times how difficult it is in the majorly time limited appointments. But I guess it's about sort of breaking down that person-centered approach perhaps into a series of appointments. And I think even if you've got a limited sort of time allocation, really just thinking about the use of language and how you phrase the conversations about weight, and ask for permission to discuss weight, and also discuss weight when it's appropriate and it's not, you know, because too often I've seen sort of weight overshadowing other appointments. You know, I've heard of ridiculous examples of patients going with a verruca and, you know, the conversation predominating about their weight. So really important. I think even in a small window of opportunity, they're through the use of language and that compassionate, sensitive and helpful person-centered approach, there are opportunities. But in terms of whether training is effective, I probably can't answer that question. But I think we need more. We certainly need more training in this area that's tailored to different healthcare professionals' needs, and also really considers the sort of key limitations and barriers to different appointment and consultation situations that training can directly address.
That's great. I just want to, there's more questions that we'll go to, but I just want to flag to people that people are sharing some very good practice in the chat and some examples of things that they're doing in their areas. So I would signpost you to all have a look at that as we go along. So just having a look at what's here. Another question, it would be interesting to see if there are any studies that assess what the capacity of local services for children and families is in each area, first, and second, what percentage of the population of need actually access the support?
Now we have a wonderful PhD student who is currently looking at weight management service provision sort of across our sort of local authorities and ICB. So hopefully there'll be some really interesting learning coming out of her work. There are the odd studies that look at uptake of weight management programs. I know I was involved in a randomized control trial several years ago looking at how we might increase uptake to local weight management programs following the NCMP, because we do know that usually there's a very small proportion of those who are eligible actually take up the program. And again, I think that relates back to the importance of that program actually being co-developed with the populations most at need, and also that the real importance of that person-centered approach. Apologies, I know I sound like a stuck record, but it's such a complex condition. There is never going to be a one-size-fits-all approach, and by trying to squeeze everybody into one intervention, it's not going to work. But also, as an academic, we really need to be thinking about making a more equitable evidence base upon which to base these interventions, because quite rightly our services are based on evidence, but when that evidence predominates from the white middle classes, we're only going to have services that will work within the white middle classes. So we absolutely need to be working with and developing research across the breadth of our broad and diverse community, so we have good evidence to base equitable service, the development of equitable services that are appropriate to everybody that needs them.
That's a really important point you've made there, so I totally agree with that. There's a question here about the practicalities again of delivering this sort of information. So on the point about using the right opportunities, it's difficult to balance it being an appropriate reason to bring up weight with being preventive. If we are to address the issues early, how do we bring up weight before there's a health associated complication without it being stigmatizing?
That is a really good question. And I think, you know, there is definitely an element of clinical judgment, knowing the person sitting in front of you. I think asking permission to discuss weight, because if that patient does not want to discuss weight at that appointment, then, you know, if they are not ready to discuss that, any interaction or any information provision will be fruitless anyway. And I think it goes back again to the correct use of language, using non-stigmatizing language, and also making clear, you know, taking away that blame, and, you know, making really clear the complexities of what drives obesity, and it is not somebody's fault. Nobody chooses to live with obesity like nobody would choose to live with any other chronic disease. So I think it is about understanding the patient in front of you, the circumstances, using that compassionate, person-centered approach, and sensitive and non-stigmatizing language, but asking permission. And if people don't want to discuss weight, leave it until another appointment when they are ready.
Yeah, because that's an interesting point, because there's another related question here, which is what support is available to parents or carers of young people who don't want to be involved in interventions because of the stigma associated.
And I think
that's
anything
out
huge
there for parents and carers. Yeah,
I mean, there's obviously there's information within the NHS website. It's quite sort of standard, and there are various different bits and pieces of digital support interventions and sort of health promotion out there. I think it's hugely variable. There's lots of noise if you go onto the web, and, you know, whether you get good or bad advice depending on sort of where you go to. I think it's an area we really need to be thinking of, but we also need to understand why those families don't want that intervention, and how do we destigmatize you know, those interventions, and make sure that families do feel able to attend without feeling stigmatizing. One of the lovely things about that is emerging from the complications and excess weight evaluation is the first service I've evaluated that is genuinely really addressing health inequalities. It is engaging with, identifying and actively engaging and treating children from across really broad and diverse populations with really complex needs and really severe levels of obesity. So I think there's some real lessons learned there, and some of that is around they are genuinely providing that joined up, person-centered, holistic approach that is really I mean, the passion of the consultants that are leading those services and the wider MDT teams just resonates when you speak to them, and those families, I think, feel sort of nurtured and empowered and supported within that kind of environment. So it really is, and it is hard within that horrible social backdrop. You know, I sometimes feel like I'm in a bit of a bubble, because you surround yourself by people who have the same mindset and approach, but sadly it isn't reflected in much of sort of wider society. So we also need to think about what we can do to continue to change the social narrative. So I've got a lovely PhD student, Lawrence, who's a filmmaker, who is making a film around addressing how we can address and change the social narrative, and how we can try and use film as a medium to change sort of individual thought patterns around obesity and reducing that stigma and blame culture. But there's not going to be a quick fix, but we need to keep chipping away, and eventually it will, I hope it will start to turn.
That's fantastic. I think the volume of information in the chat, sharing good practice and all the questions as well. I'm scooting through trying to find the questions in all of the good practice there and the sharing of information. So thanks very much for that. But it definitely shows that this is a very important topic area that people feel quite passionate about. So I've just got time for a couple more questions, and there's one here. Oh, I've just lost it again. Every time there's one posted, it jumps. Tower Hamlets closed its weight management programme for children and young people due to a lack of good quality evidence. I personally think it is a good use of resources to redirect this money to prevention. What's your view?
It's the constant question I'm asked. If I had a pot of money, what proportion would go to prevention, what proportion would go to treatment? And it's a really difficult question to answer, because obviously you need resource in both. In an ideal world, if you could prevent obesity occurring in everybody, that would be perfect, but we're living in a world where that hasn't happened, and we're living with large patient groups who have or who are currently living with obesity, and ethically we have to ensure that they are treated and supported to our best ability. So I think, yes, it is super important to have that resource into prevention, and we've seen in the slide presented today, the earlier we can intervene and prevent suffering in later life, that's absolutely got to be the priority. But equally so, we absolutely must deliver the best possible care to those that are currently suffering. So I think it will be a 50-50 split. I'm really super supportive of effective early prevention, but absolutely not at the neglect of those who are currently living with obesity and in need of care.
That's a great answer, thank you. We have a question here: is there guidance about what support should accompany the Year 6 obesity letters in schools? This is also as a trigger of eating disorders, and there's no support identified for parents.
So I know UCL is currently doing some NIHR commissioned work on specifically this, because I think there's been a lot of questions raised, and I think that was one of my research questions, was around what are the sort of adverse effects of actually identifying children as living with overweight and obesity, and particularly within the field of disordered eating and eating disorders. And that's an area I am hugely passionate about. So I'm really hoping that work carried out, it's led by Claire Llewellyn and sort of Simon Russell and Oliver Mitten at UCL. I'm hoping in the next year or two there will be some really useful insights and resources that will come out of that work.
That's brilliant, thank you very much.
They're working directly with the NCMP team, so hopefully there should be a quick transition of insights into resource and learning. Brilliant.
Could I ask you to flick on to the next slide, please, Louisa?
Certainly can.
There's a wonderful presentation you've just given. There were so many questions, we obviously didn't get to them all, but we can share the good practice that's been shared in the chat and circulate that round to attendees. And the recording of this session is going to be available on the IHPE website in due course, so you'll have access to that. So if you did miss the beginning or miss any section of it, or you couldn't hear the audio, you'll be able to access that on the recording. If you'd like to attend any future masterclass events, you can find out more and sign up at the link here on this slide. Importantly, the Institute of Health Promotion and Education always welcomes new members, so please do take a look at our website, consider joining us. We are a charity and we're providing these events at the moment free of charge. So if you did enjoy this, please do consider making a donation of any amount at all. It would really support us to provide more of these events for you to engage in. Finally, please do fill in our one-page evaluation survey. This takes only a minute, but it will really help us to shape our future activities and plan out what we can offer next. And you can complete this via the QR code here, or through the link that will be emailed out to you from IHPE. Once again, I extend a huge thanks to Professor Louisa Ells for sharing her breadth and depth of knowledge in this fantastic presentation and Q&A today, and I really hope you enjoyed this session. So we've come to the very end now, and we hope to see you next time. Thank you all, and thank you, Louisa. Wonderful presentation.
Thank you very much, and thank you to everyone for joining us.